Good afternoon, everybody, and thank you for joining this session. For those of you who didn't join any of the previous sessions I was in, my name is Tina Lavender, and I'm currently Professor of Midwifery at the University of Manchester. But as from Monday, I'll be Professor at the Liverpool School of Tropical Medicine. So it's particularly nice for me to be sat here in one of the Liverpool School's buildings. I'd just like to introduce to you the rest of the panel. So perhaps Annie?
Hello, my name's Annie Portella. I work in Geneva at the World Health Organization in the Department of Maternal, Newborn, Child, Adolescent Health and Aging. Happy to be with you.
Thank you. Salome?
Thank you very much. I'm Philomena Fumo. I'm an associate professor at the University of Cape Town. I'm an obstetrician and gynecologist, and I'm also head of global surgery.
Thank you. And I also have Helen with me.
Yes, so I'm Helen Nabuera, and I'm a pediatrician. I'm based here at the Liverpool School of Tropical Medicine, so I'll be moderating, just supporting with the questions that come through from you. Thank you.
So before we start with some presentations, I just wanted to explain the aim of this session. This is supposed to be an interactive workshop, and the idea is that we take some research or some potential research and we use that to show how it could be turned into an implementation project. But we've all been doing quite a lot of talking, so we do want the audience also to contribute here. So, you know, if you do have a pen and a piece of paper or your keyboard, you know, type down some of your own thoughts, any questions you might have, because we're going to leave ample time in this session for questions, answers, and other experts to contribute as they feel that they want to. But in the first instance, we're going to start off with Annie, who's going to give us an overview, and then we'll move into some projects. So Annie?
Okay, can I share a screen here? It says share screen, should I try?
Yeah, we can see your screen, Annie, that's fine, you can go ahead.
Okay.
So Annie, please go ahead.
Oh, yeah, I'm trying to. Sorry. Okay. Here it comes.
You don't need to share, Annie. Just talk and then say next when you want us to change the slide.
Ah, okay. Sorry. That's perfect. Okay, now I'm set up. Sorry. So I'm not going to talk about respectful care, I understand. It's just trying to give an overview here of respectful care in implementation research. But just to say respectful care, like many other evidence-based recommendations, you know, it's a persistent challenge despite evidence-based, despite, you know, widespread adaptation of policies and even sometimes being included into standards or guidelines, countries struggle with how to implement them. And throughout the day, we've been hearing about, you know, different elements of respectful care, but also different elements of implementation research. And I thought it would be interesting to look at different frameworks for implementation research. And I'm just going to show two. But again, there's been so many frameworks that have emerged in recent years. And when we talk about implementation and implementation science, I sometimes wonder if we all have a common interpretation and understanding. I think some basic tenets are the same. And then I wonder sometimes if though all of the tenets are the same. And I really have used kind of Pierre Barker's work around dominant themes from scale-up frameworks. And that's when I think of implementation research. I guess I'm looking at it from the perspective of how do you develop a local model or a contextual model that allows implementation of an intervention or design of a model, and then that model to be taken up in the system. So Barker and colleagues had 4 different steps for that, and they called it setup, which prepares the ground, develop the scalable unit, then test the scale, and then go full scale. And in my experience, implementation research teams often feel frustrated with these 4 steps, in part because projects are 2 to 3 years or 2 years, which again are very short. If I'm thinking of these these 4 steps, normally by the time I get to a setup and developing, and then it's a very short time to start testing for results, and then even a shorter time to, if you're thinking about improving the model and scaling up. And so that's probably a big frustration. And then a second frustration, and again, this is where I think sometimes we have different views, is that even though often we're talking about taking evidence-based interventions and scaling them, a lot of times at local level or at national level, there's still a burden of testing the effectiveness of an intervention or proving the effectiveness of the intervention in that context. So I find we struggle with wanting to focus on implementation research that in fact highlights processes and allows us flexibility, but nonetheless, we're somehow provoked to have a study design and make sure we're well documenting outcomes because it's important to show impact. Can we go to the next slide, please? So sorry this is so blurry, and my colleague and the champion of this study, Tamar Kabakian, is on the line. This is a model from an implementation research that was conducted in 3 public hospitals, one in Syria, in Damascus, one in Egypt, and one in Lebanon. And again, this model shows maybe 3 of the steps there. And in this project, what we did was, again, the formative research, and then kind of a pre-implementation phase where it was the setup based on the formative research, setting up implementation. And then the last phase was implementation and testing of that model. And I think a strong component of this was, I don't know if any of you were present in my talk earlier, but a really strong component, not only of the formative research phase, but what we learned thereafter was this co-production term, if you will. So identifying in formative research the barriers, but then really working with staff in the facilities and in the universities to address the barriers, particularly the barriers that providers have. And I don't know, later on, Tamar, take your pencil out because I'm sure you'll want to say something to that. But again, that was probably, again, not only for formative research, but for going forward, that whole dialogue and making sure providers knew we were addressing their barriers. I felt like that was one of the keys to making it work. But again, what I wanted to really highlight in this model was the 3 phases. And now if you can go to the next slide. This is a model from kangaroo mother care research that was done in Ethiopia and India. And what slightly differs here, it's not very different except that, visually, but this one tried to go beyond, because it wasn't only just, there was continued iterative learning of a model before testing it. So even though there was formative research, there was work to, 1, develop a model, but then continue program and learning through a learning team to improve that model till the team felt that they had achieved a model that would achieve the objective. So again, it's slightly longer or slightly different than the previous model I showed, because the intent wasn't only to find a model, but really to try to perfect that model in the system, or get a good model in the system that could eventually and be on its way to scale up. So I don't know if the slight differences are clear to you, but again, the whole co-production part, that whole, and I'm even expanding it here, and Tamara will probably avow that that was very much part of the earlier project. Again, the implementation team really has to work hand in hand with the research team. And in some settings, I've found that a lot of time the research team struggle with this. They're not used to this. They're used to a protocol that they stick to and then finish it, and then complete it. And this whole iterative pattern, this negotiating with implementers, this changing of what they're doing, of course, except for the evaluation part, I felt was quite new. So to me, that whole part is embedded in both the models, but again, slight difference between the models. So I just wanted to start us off with thinking about that, the differences in models, what we really are trying to achieve. Is it learning? Is it evaluation? Is it a combination of both? And also this part of how do you keep learning alive throughout and probably even after, even though it goes to a reduced scale once the research part stops. So I'll stop there and over to you, Tina. I hope that was helpful.
That's gone. So I'll start with, so how did you involve labor companions in research? At what stage were they effectively involved? That's from Anonymous.
Is that for me? Sorry, you were on mute and I only heard part of that. So I didn't hear your beginning part.
So one of the questions, I guess, in some of the model that you showed, one question is, how did you involve labor companions in research, and at what stage were they effectively involved? That's the question.
Again, I'm feeling shy answering, but Tamar, sorry, I'm speaking for us, and you can write in the chat anything. Well, from the formative research, again, it highlighted speaking with women. Who did women want, and how did they want a labor companion, and did they want speaking with women's families and women's families and community members. Again, in these three countries, men weren't the labor companions. It was going to be a female labor companion. So from the very beginning, they were involved. And in that phase, where is a slight testing phase before going to the model, again, you received feedback from the labor companion. Just to give something anecdotal, something that really bothered the providers is they felt labor companions don't stick to their job. I don't want them walking all over the place, and they need to know their do's and don'ts. And the labor companions felt they needed better orientation. So then again, the project responded in putting up posters on what is the role of labor companion, and also giving a slight orientation to the woman and the companion before labor, before going into the labor room. So that's just an example.
Thank you. You talked about the kind of like the separation between the researchers and implementers. So a question from Valentina Actis Dana is, so how do you facilitate that integration, and what lessons are there that we can learn from what you've done so far?
Okay, I'll say my part, and then I'm sure the rest of you all have a number of this. I really feel it requires facilitation, just like any interdisciplinary conversation requires facilitation. And I think it's after a first experience that a lot of times, to me, my colleagues who are researchers and did their first implementation research experience would always comment to me, oh, how different this is, and how hard. And I think from the implementer side, sometimes they can feel like, oh, these researchers don't know our reality. So it's like any interdisciplinary dialogue. It requires the facilitation, the commitment. I feel in the projects I've worked on, government leadership has been key, and the fact that the researchers recognize that for implementation, government leadership is key, and the government, kind of helps to steer things. I feel those were kind of big success factors.
I think maybe we will move on to Salome now and then come back to this discussion, because I think this has been really interesting, and I think that a lot of people have mentioned co-production, and it's a word that's very popular at the moment, but I'm not sure everybody really does do true co-production, so it would be good to explore that a little bit more at the end. But perhaps if Salome could give her presentation.
Right. Thank you very much. And my presentation, I mean, it's not an implementation science. It's really about us trying to understand respectful maternal care in an African setting, and and I'll just talk briefly, and the discussion will really be about what we can do with this kind of study, and what the study, it has started, but I mean, this is really to generate more discussion. So next slide. So we looked at doing the study in Nigeria, and many of you, by now will be quite familiar with some of the problems that in maternal health in Nigeria. Very high number of maternal deaths, second highest in the world. The high number of deaths really reflect the high inequities between the rich and the poor. And then the quality of care is often a deterrent. When people don't feel respected, then they don't seek care. And these are all the questions around: is disrespectful maternal care really associated with a high mortality rate? And these are some of the things that we wanted to look at, especially as obstetricians. We like to look at the clinical factors and what could have been done medically, and very little. Often, when you bring up RMC, there's always questions about how, what is the real association. Next slide. Next. And so I just put a few assumptions that we generally make. You can go back a slide. A few assumptions that we generally make as healthcare workers, and trying to understand this, that, healthcare workers are familiar with RMC. You kind of assume that there is a reason why there is disrespectful maternal care. It's not that the healthcare workers do not understand. I've mentioned that deaths lead to deaths are linked with women not accessing care, not having access to care, and women not having quality care available in their setting. But then RMC affects the utilization of healthcare facilities, directly linked with the maternal mortality. But there is a link with whether women will use their care when it is accessible. And then the attitudes of the patients and the culture, that's obviously another important part of this. We don't often consider the attitudes of the patients. We really look at the attitudes of the healthcare workers, and that's what we try to look at, and where we can bring changes. But these are just certain assumptions that we make. So next, I'm going to talk about the research question and the study that we developed. And so what we're trying to look at was, what are the strategies to improve RMC in this setting in Nigeria, and then how can RMC be implemented? And so the study that we're currently working on, it's strategies to positively shift readiness for change to a respectful maternity care practice during childbirth in public health facilities. And this is happening in Ibadan in Nigeria. Next slide. And so this is a study that's being done by one of our PhD students. And so what she's really looking to understand, or to determine the proportion of women that are delivering that actually experience respectful care, wanting to quantify this, to look at from a qualitative perspective, to understand, what are the healthcare workers, what is their readiness to change practice, and to identify some of the barriers and facilitators for change. to also identify strategies to positively shift the state of readiness to change to respectful maternity care in this setting. And that's just a summary of the work that we're doing. And we can open it up to discussion or for questions. So I don't know where we would put this, kind of, because it's not really implementation, but it's just to understand at this point, as researchers, what the situation is and what we can do, and so that we can plan the next steps if this study goes well. Thank you.
The implementation.
Okay. You can
But
close
I think
that.
it's a good foundation, isn't it, for implementation research, and I'm going to present a similar scenario shortly as well. So I think we'll have a lot of discussion about both these prospective studies building on work that we already know or do. I'm going to take the kind of chair's prerogative, I suppose, and just ask a question to either yourself or to Annie, really, but related to your comment about readiness to change. And I just wondered how you see behavioural change and the science around that linking with implementation research. And I'm not sure whether Salome or Annie will answer that or has an opinion. Maybe Annie, do you have an opinion on that?
Salome, do you want to go first and then I compliment?
So, perhaps I can go first, and from my perspective, and I'm going to talk about this also tomorrow, because there's looking at the implementation and looking at what can you change, what systems can you change, what needs to do, what can you do so that it's feasible. The environment is enabling for women to practice, for RMC to happen. But then there's human behavior as a separate topic, and often we don't look at human behavior studies. We're not really good clinicians at looking at human behavior and how that is all successfully able to understand that. But I think it needs to be, both need attention. We need to look at both sides of the coin if we're gonna improve things.
Thank you, Salome. And Annie?
Yeah, no, I really agree with you. To me, it incorporates, so many of the things we promote in a behavior change strategy. But again, looking at all the different factors that affect behavior and attitudes, and moving people from either knowledge to practice. But again, getting off this idea that it's just knowledge that impacts. You very well said, it's how are they ready to move to that, and again, it's not always just because I don't know. And I find implementation science really has to combine an individual behavior, a group behavior, and then a systems behavior. And all three of them, that whole change management process, if it's truly to be successful, requires really good management. And again, it's not usually in the skill set. And so these skills that people tend to think are soft skills, because they're not clinical skills, in fact, are key to the uptake of many of the clinical interventions, as well as respectful care and quality of care.
Yeah, totally agree with you. Helen, is there any questions?
Yeah, so there's one from Professor Veronique Philippi, which I guess is related to what Salome was saying. So intervention sciences seem to be presented as a response to all research needs with respectful care. Are there any other research approaches that may be useful? I guess, Salome, maybe you can pick up on that, because you had brought that up a little bit in your presentation.
Yes. Yeah, it's a challenging one, because it's so many things. Especially in the work that I do, my everyday job, we're looking at issues like social justice. you know, and it's when you start looking at health systems, we want to fix problems and we want to find key interventions, but sometimes it's attitudes that you need to change. It's advocacy might be more, you know, might bring more results than simply putting guidelines and standards and norms, you know. So it's very challenging to, you know. But I think from my side, we need to think outside of the box, and it's you know, which is why I also said that we made a few assumptions. They may be wrong, but even in some of the earlier talks today, it was highlighted that no one wakes up, goes to work, and says, "I'm going to be abusive today," or "I'm going to be disrespectful today." Meaning that there are other things that we need to look at and find solutions in looking broader than we normally do.
Yeah. Thank you.
Any more?
Yep. And so one of them is from Radiga Petrov. He says, are there any known disadvantages or harms or opportunity costs for respectful care? Do we know of any disadvantages or harms?
I mean, you know, yeah, I mean, you know, it's all about humanity at the end of the day. You can't be too nice. You can't be too giving. You can't be too, you know, it's a values and value systems. And you know, you can't be too friendly, you know. So I don't think we can look at it from find disadvantages with RMC. I don't think, I really wouldn't want to say that they are.
I would agree with that, Salome. I don't see any disadvantages of respectful care, but it kind of brings on quite nicely to maybe my presentation, but I'm sure we'll come back to some of these issues. Because I've also looked at respectful care and looked at the possibility of some implementation work. So if I could just have my slides. So next slide, please. Sorry, these are all in bullets, but you can just zoom them through. So those of you who were at my last session will have already seen this slide, but this was just set in the context about 2.6 million babies dying globally before or during birth each year. And we all know what a tragedy is. And I don't need to say this again to this audience, but respectful bereavement care does have the potential to help the grieving process, and this is something that we're finding within our research that isn't really supported very well, and therefore women and families are suffering. So I wanted to kind of just lay the foundation for some potential implementation research and then get some views on perhaps how is the best way to do this. So if we could have the next slide, please. And this is going to build on the exploratory work that we did as part of our NIHR research group. And one aspect was to explore parents' lived experience of care and support following stillbirth. And to do this, we used a phenomenological study which was conducted in Kenya and Uganda. And this involved interviews, in-depth interviews with 75 women and 59 men who had experienced a stillbirth of their baby in the previous year. And if we go to the results, as expected, parents described devastating impacts and profound responses to their baby's death. There was poor communication, environmental barriers and unsupportive facility policies and practices meant that the needs really were not met, and women and partners encountered stigma, engendering feelings of blame and increasing isolation. So all of these things were compounded and prevented the recovery of women's psychological well-being. So we concluded that parents were not always treated with compassion, lacked the care or support they needed after the death of their baby. And it was really good that Annie earlier on in her talk was talking about respectful newborn care, and she introduced Emma Sachs into that as well. But we're finding that in bereavement care, the there often isn't any respect, particularly for the baby. Next slide, please. So these were just a couple of quotes just to illustrate this, and you can see from the first one, you know, that what you want us to help you with, your think has already died. And this was to a mother in Uganda. If your baby was still alive, who could have saved him? So on that note, help yourself, because we also have no way of saving you. So it's also the baby was not valued in any way. And the other quote, which came from Kenya, was, you know, a mother is a mother even to a dead body. I would have wished to hold the baby, but I think the nurses saw my grieving and they thought that would have aggravated my pain more. So they immediately took the baby away. So this was about the lack of individualised care and finding out what the woman actually wanted. And I think that, you know, the baby's existence clearly wasn't validated and opportunities for parenting really wasn't supported. And I actually think that this is such a complex issue because you have all the cultural influences, all the traditions. The health providers are not adequately trained to be able to deal with these situations, and the woman is often has to seek support and help from a family, and she's not often the decision maker. So all these things need to be changed in a culturally sensitive way, which is appropriate. So I just wanted to use this as the foundation, really, to say how could we actually use this kind of information to have an implementation project that's going to make things better, not only for the woman but also for the family, and that's acceptable for the local setting and is also culturally sensitive. Next slide. And next. So I was going to throw these questions out to you, really, and just as prompts for discussion. Although I'm pleased to say that we are getting lots of questions, so the prompts will not be that necessary, but I'll throw them out there anyway. So I was thinking, you know, who would be involved and engaged in this process? Who would be the key people if we were going to move this to an implementation project, or indeed move Salome's project, which is very similar, forward? What type of design would you use? I mean, Annie's talked about different models, and I know that Sally this morning talked about different stages of implementation cycles. You know, so what design would be used? How would you measure the success of this? How do you ensure that it's culturally sensitive? You can just keep changing it. And what would be the challenges and solutions to this? So these were just some of my kind of thoughts, really, that I thought we could perhaps discuss. And I don't know whether these relate, Helen, to any of the questions that maybe we're getting also on the app.
Yeah. Should I field them?
Yeah.
Yeah, great. So, Annie, this is a question for you, and it's from Atene Asefa, who's from the University of Melbourne. And he said he was involved in the KFC implementation research project in Ethiopia, and his question was, the main problem was ensuring ownership and sustainability after the iterative model of development. So he asked, what evidence is there in the field to generate buy-in to ensure ownership after the iterative process? You're on mute, Annie.
Annie, we can't hear you at the moment.
Sorry, I was on mute. Sorry, from the beginning, I didn't feel this project had a problem of ownership or embeddedness, because from the beginning, one, KMC was national policy, and the government was very committed in both sites, both countries, to bringing it forward. And two, the project was really set up as the ministry, and in Ethiopia, in the case of the regions, the regional health authorities were really involved. So decisions were made from them. The research was conducted in public facilities, and it was public, facility staff who was guiding and working. So I felt in this case there wasn't there wasn't a problem of buying it. It wasn't somebody coming in trying to sell it, but from the beginning, the government had established this as a priority and really saw it as something that they needed to take forward. So again, I always feel that's a great advantage. Of course, that's WHO's focus is how can we help government and support government in taking forward policies. And this is a good example of how research, university, and government work together to bring forward an effort.
Thank you. Thank you. So there's a question for Salome. It's from Sabina Wakasiaka, who's from the Africa Regional, she's an Africa Regional Coordinator. And her question was really about, I guess, the study, which Salome, I believe you're yet to do it, but her question was, so in your study, what was the greatest challenge and how did you address these issues to bring about desired change? You're on mute, Salome.
Sorry about that. So the study is currently being done. It's as a PhD. We're in the data collection phase now. And I also cannot disclose too much about it at this point, but really just wanted to use it with the permission of the guys to just share a few thoughts around it. But I mean, so a lot of, because it's an academic study, also going through all the permissions and you know we've we've gone through various challenges and various stages, also trying to collect data during the pandemic, so I won't be able to answer a lot of the specific questions at this point, but in the future, uh, I'd be happy to give more details.
That's great. Thank you. Thank you. So this from Francesca Quatri has asked, this is a question for Annie. She says, thank you for a great presentation. Her question was, how do you find the right balance between compliance to existing guidelines and recommendations and iterative, more spontaneous, context-tailored approaches to care? So I guess what the new evidence is showing compared to the existing guidelines. How do you find the right balance in compliance?
Yeah, the construction of knowledge. I mean, again, there's some, it's quite, I agree, it is quite a balance in what are actual practices versus how much a change, any kind of new recommendation is. What we talked about earlier is, do health providers understand the change or appreciate the change? For example, in the labor companion example that was given, providers really didn't think that was a good intervention or had their concerns about the intervention, and so I think sometimes interventions have their core component, particularly clinical interventions, that you can't play with. But again, it's the systems part of it that you're adapting and making. The spontaneity and the context part, I feel, has to do with those bigger, more complex interventions and embedding it into the system. Not as much. It wasn't a question, if I can use then the KMC example. It's not a question of, kangaroo mother care has its requirements, exclusive breastfeeding and certain hours of skin to skin duration. Now, how mothers felt comfortable doing it, who they wanted to support them, was there the right environment for her to be able to do that? Is the baby stable and the mother can go, not when the baby and mother can go is defined by science, but then the rest of it and the other part, is a context specific that I do feel can depend and can be structured according to the needs and the preferences. So it's a good question. It is a balance, and it's not all an open playing field. There are some elements of an intervention that has to be preserved. But again, I think the part that implementation science brings to it, or implementation research, is, how does it work and uptake in a certain context?
That's great.
I don't know if that answered the question.
That's great.
Yeah, that's great. Yeah.
Thank you.
And anything else?
No.
Not at the moment. Well, I mean, I think that one of the questions I might like to just add to a little bit in terms of the challenges, and I wonder whether Salome has had similar thoughts or or tackled it. But one of the things that we've been thinking about with respect to developing respectful care proposals is, how do you implement something in an environment where those within the environment feel that there isn't a problem? So if you have a facility, for example, that doesn't believe that they actually do provide disrespectful care, then how would you go about implementing changes? And I'd be very interested to hear what you think, even, and what the audience think as well. Salome, do you have a response to that?
Yeah. It's, and it's very interesting, and I think, I mean, going back, touching on something that Annie also said at the beginning, and in our case, it's, people come to us, students may come to us and say, we want to do this study, and what we try to do is to do the study in your country, and we will support you. So I'm in South Africa. I haven't been to Nigeria, as part of the study, but I'm trying to providing the mentorship, the support, the supervision for this to be done, because so it's very unlike us looking at a problem in another country and saying, let's help you solve this. It's people coming to us and saying, we've got this problem, and we want to solve it, that give us the means and the mentorship so that we can do it. And so some of the interesting things on our side were, as we were trying to understand, how does RMC look, or what is RMC? How would you define it, and what is the worst? What kind of abuse happens? And it's very interesting when we are surprised and shocked that things get so bad, or things can, because we look at it from our perspective, and we understand even disrespectful care, but this is as far as it goes in our city. So when somebody comes and we want to understand what actually happens where you come from, we also get thrown back just trying to imagine it. And so I think to that extent, or that it's really being responsive to a problem that people have noticed in their local context, and trying to see how we can help. But of course, now the researchers would see the problem in their context, but convincing the clinicians that this, might be the next step. But I think already for us knowing that there is a group of people that have identified a problem and want to contribute and see it as a challenge, that it addresses some of the contextual barriers that we could face with these type of studies.
That's great. Thank you, Salome. Anything else?
Yes, I've got a question for Annie. It's from Francesca Quatri again, and she asks, do you have any direct or indirect experience of proposed models being rejected because they are not sufficiently compliant to the existing guidelines or recommendations?
I can't really think of an example. Maybe Tina or Salome can. I mean, because generally in our experience, you come with a global recommendation, or that a context is interested in adapting. So it's maybe slightly different in my experience. Are there things that happen during implementation that you have to keep your eye on because they deviate from maybe good practice or from safe clinical practice? Absolutely. And that comes up. And again, that's why you need that good balance in your research team of someone who really knows, the science part or the health part, someone who really knows the social science part, someone who knows the implementation part. And I think if this is answering the question, I think, again, someone had mentioned in an earlier session, just again, this interdisciplinary team is probably also the secret sauce, because it does come, you're required to have your eye on several elements.
That's great. So maybe, Salome, I'll direct this one to you. It's from Statipunt, and the question is really relating to COVID and labor. and he's asking, how does COVID impact the labor companionship, and how does it impact the progress achieved so far?
Sure, it's been a challenging one because on one hand, a lot of hospitals have simply said we won't accept a companion. Even the husband is not allowed to be there. Whilst national guidelines, etc., may not necessarily say that, but hospitals do put such rules and separating mom from baby. And mom test positive for COVID, they're not allowed to see their baby for 5, 10 days, and there's been a lot of mental health issues, a lot of RMC issues, and you're working with healthcare workers who are stressed, more stressed than usual, and it's patients that are more stressed than usual. So the effects of the pandemic itself on the system, on the human resources, on the patients and health seeking behavior. But we know that it's a point in time. A lot of countries have already reached their peak, and I think things will settle and will normalize. So I will normalize slowly, gradually. So I don't think we can throw away all the hard work that has been put into this over the years. I think the work needs to continue.
That's great.
Thanks, Salome. We're nearly out of time now, so I would just like to ask Annie maybe just to give us a few closing words, if that's okay, as our implementation expert.
Is that is that right?
Yeah, you're very modest, but we know you're the implementation expert on this panel.
So nice of Tina. Actually, I just wanted to say one challenge, Tina, and I was going to throw the question to you, not to get out of saying a few closing words, but I know one of the things you and I have struggled with in our discussion is, we've all been talking about co-production, and we talk about co-production, we talk about documentation, we talk about process. Yet, nonetheless, I find those same things that are core to implementation research often are a challenge. Co-production, when we send a proposal, often we have to write exactly what we're going to do, and it's quite difficult when you can say, okay, here's some of the big areas, but with the local team, we would define specificities. I'm not sure donors are always comfortable with that. And so I feel that's quite a challenge. I mentioned earlier about timelines. And again, research projects are often funding and smaller funding is for 2 years, when in fact at 2 years, you're probably just only hitting your stride in implementation. And that's, the worst time to evaluate, and you're not there yet at embedding it in the system, and then things stop, so that's also quite a challenge. And then lastly, again, particularly these kinds of interventions, we talk about documentation. So I document context, I document process, and I feel, I've seen us all struggle with, well, what do I do with all of this information? One, it's really hard to synthesize. I may use it within the project, and you use it for project management, but I feel we haven't been so good at helping to better synthesize it. And then the part is always, how do you share that with others? If I truly want others to be able to learn from my implementation, when I write the paper, I journals and the public want the biggie, they want the impact, they don't want to hear all these nitty-gritty details. Yet when someone wants to learn from my experience, they need to hear all these nitty-gritty details. So we're really struggling with how to help in implementation research and in implementation. How do you help document all of these things? How do you help what do we do to publish them? How do you help to synthesize it? And then how do we make learnings available to others? I feel we're not there yet. And maybe, one of the good things about respectful care is that it is such a community, and there are so many partners involved. And in part, maybe, I think someone said earlier about about, the frustration that we've been focusing maybe only on measurement of the problem and not moving to implementation. But now, as everyone really is gearing up for this implementation mode, I think it would be interesting amongst all the partnerships to see how do we truly support each other and share these learnings. So that's from my side. Over to the rest of you. And thank you. Thank you for inviting me today.
We have actually run out of time, but I just want to say you made some really, really important points then, Annie, and hopefully GLOW is elevating the status of implementation research slightly, and we know that the respectful care conversation has started internationally, so let's hope that there are changes ahead of us. Thank you, Salome. Thank you, Annie, for a great conversation, and thank you to the audience as well for the great questions. We are going into a break now, so if you want to just go and do a bit of yoga, look at the posters, listen to the music, go and get yourself a cup of tea, that's fine. And then we'll be back at 4 o'clock for the Pecha Kucha talk, so don't miss them, they're going to be great. Thanks very much.
Thank you.